say I'm going to turn it to flush, the flow meter goes higher than 15 liters. It can keep going and going and going. You don't know where the little black ball is going to. Eventually, it will stop, and it gets louder and louder and louder. That's true flush, and it is loud, and you're about, depending on the flow meters, some go to 25 liters, some go to 40 liters. You don't have to do the true flush, but at least 15 liters, y'all know.
So the intubator, when you do the checkoff, intubator has to do certain things, and the assistant has to do certain things. So over here on the list, positioning the patient is the intubator, okay? And who is going to get the mask ready and the ambu bag? Assistant. Make sure you know that.
Question, since we're working in pairs, can we communicate each other, or is that like?
Absolutely.
Except of like, hand me this. But if you go yang, you are forgetting to inflate
No,
the
no,
cuff.
I'm not saying.
That's different.
Yeah.
So yes, totally works. You know, hey, I got this, hand me this.
So you
are
can't
ready?
say yang, inflate the cuff. You can't say that.
No.
He has
That's
to
when
know
you
to do
know you're waiting for him to do it, and you are gonna have a hard time. I know you.
it. And I'll be like,
Do it. That's the hardest part. But yes, communication is key. Are you ready? I'm not ready yet. Okay, I'm ready. Yes. You know, stuff like that. You know, yeah. But then the part that's hard is telling the other person what to do. You know what I mean? So if you just sit there, they'll get the clue, hopefully, what they're forgetting, and then just get it real quick. All right, so I don't know what y'all have done in CPR or not, but we're also going to be on the checkoff on manual ventilation. That is simply, this needs to be over the mouth and nose correctly. You take your 2 fingers and make a C around the mask. With your other 3 fingers, you grab the chin and pull that trachea so it's straight. If you're bagging somebody like this, their whole trachea is cut off and it's going to be hard. So it's over the nose and the mouth. Do your C or E and pull it back. Slowly intubate. I've had at least 2 students in the hospital say to me, we had unconscious patients. And they're like, no, we had awake patients that were intubated though, we were going to CT scan or whatever. And they were like, okay, I'm going to breathe with myself. And every time they took a breath, they pushed in. Like they had been told that, because both of them 2 different days said it. That's fine if the patient is paralyzed and not breathing. You know, it's usually about every 3 seconds. But the problem is, this guy was spontaneously breathing. He was exhaling as they were pushing in. And she went, the bag, I can't get the bag to work. And a nurse said, push harder. And I was like, no. And she's like, am I supposed to get resistance? And they were like, push the air in. And I was like, oh my God, they're exhaling. Do not push when they're exhaling, or you're going to pop a lung. So I don't know if that was from a CPR class or something where they learned to do it with their own breaths. If you see the chest rise, push in and make their breath bigger. You know, try to synchronize with them. If they're not adequately breathing, though, you do it about every 3 seconds. Does that make sense? So yes, if they start coughing, wait for them to finish coughing before you push the next breath in. You don't want to aggravate anything, because that's just going to aggravate more and more coughing and so forth.
But if you're in a code, the CPR, the new guidelines, they tell you 2 ventilation and 30 compressions.
And that's tricky too, because you don't see anybody ever stop and go, I can't breathe. They're just going, and you just kind of try to get your 2 breaths in around the compressions. Because if they're pushing, how easy is it going to get a nice breath in? So you will see us give more breaths occasionally, because we know our breaths are not going in 2 to every 30. But yes. So anyway, the major is grab, pull back, that's your head tilt, chin lift, smooth, wait, and you will hear the exhalation. Sometimes you'll hear the mucus as they're exhaling. Then breathe again. And a good bag, not just, do y'all know how much air is in an ambu bag? If we could get all of it out. Now granted, we don't do that every single time. There's 1 liter of air in here. So just kind of know in your head.
And also, one thing I just remember, we were about to intubate a patient. The patient was coding actually. The nurse actually had the ambu bag hooked up. So we thought that this is hooked up, ready to go.
It was up to air.
So we came, first therapist came in, and the nurse actually was already bagging the patient. The therapist picked up the bag and started ventilating, right? Later on, we came to find out that was hooked up on an air flow meter running 15 liters per minute. Air flow meter. And another incident was happening. It was like right in the middle of the whole thing, people running around. It came off. The actual thing came off, and the patient was, they were bagging with nothing. And the patient passed away, and then they looked around, oh, oops.
Or flow meters, it's hooked up to, the flow meter's not on.
But when I was coming in late in the hospital, she told me to wait until the patient exhaled and then give me work.
Yes.
You bag on it and inhale.
So yes, nurses do not look at those flow meters. It is not in their nature to double check the flow meter. They will grab the bag and start bagging. It's our job to check that flow meter. And it can get loud in the room. You might not hear the flow. And if sometimes you're too far away from the flow meter to see if the ball is all the way up or is it off, if you take this and hold it up to your ear, you hear the flow coming out of the reservoir tube. That's the trick I
You
just.
also make sure that's
pulled all the way.
Yeah. This should be, if it comes brand new, it's all folded up. Extend it out, but just go, and you will hear it echo real loud.
On the checkoff, we probably have this ambu bag like this, okay? So you need to come in, extend it out,
Assistant would
hook
do
it
that.
up, and tell us this is actually on flush. Don't tell us 5 liters per minute.
15 or,
Yeah, 15 or higher. We don't want anything less than 15 or, we don't want anything less than 15. We just want to see it
What's
flushed
the
out.
required length for that to be 100% reservoir? I remember reading it the other day and I forgot. There's supposed to be there's a length requirement for that, which I think that's too long, but, well, I don't think there's a too long, but that's longer than required.
I don't know.
I don't
Yeah,
know.
yeah, that's something.
'Cause that would get.
Well, that's dependent on the type of ambu bag. You look at that one, that doesn't even have one. Doesn't even have that.
Yeah, some have real skinny ones, some are, all I know,
See, John, this one right here?
Yeah,
oh, that's
Yeah, I
got a
see.
bag like
Little
an
bag.
that's the same thing as a
So-
non-rebreather concept.
The way they design us.
That's for coding, and they're just not getting.
If you can't get
You
it
can't
right,
get them, just go.
you're screwed, exactly. Yes. Now, sometimes will happen, it'll be too hard, the patient's anatomy or whatever, then he might hold the mask securely while I just concentrate on squeezing. You'll see that a lot too, or if I can't get my hand around the whole thing, or it's having a hard time, you sometimes use.
Ventilating
You'll
with,
hear the air
Yeah.
flapping.
and ventilating is extremely important. If you don't ventilate this patient right, the patient is going to die. So in your mind, I'm going to save this patient. So when you really ventilate, just look at the chest and see whether it's right. If it's not moving, you're not doing a good job at all. So try to reposition them, then ventilate again. Just don't bag the patient, and if you don't see any chest rise, just reposition the hand.
Many times you see people doing this.
Yeah. And the doctor will come in and get so mad at you.
Hyperextend that airway. It's I'm not trying to rag on nurses, but it depends on what floor. Remember, there are non-critical, like, nursing home floors. They're not doing this stuff every day. Okay, so, is that non? Okay, sorry. Okay, no. All right. I guess we'll go back and forth between intubator and assistant. Maybe my assistant, then we'll switch up.
Okay.
All right, so Benny has connected the ambu bag and it's on. I am now positioning, I'm back up to number 2 on the intubator. And I am resuscitating. At this time, all I'm doing is bagging while everybody else is getting ready. What if he starts throwing up? And what do I need to do? Suction. If he's got mucus in there as I'm bagging and I'm just making the mucus foam, or it's in the way and I'm not getting good air because there's mucus in there, you've got to have a yanker at the bedside, on and full. Screw the whole 100 and 120 when you're in a code. Make sure it's on and right there.
Here's your oral yank hour, suction is ready.
Now, as soon as we, intubate, what if all this blood starts coming out the ET tube? Am I going to use the yanker to suction the ET tube? What do I need? Catheter. Just have one off to the side in the wings. And that all comes in the code card as well. A yanker and a suction catheter. So once we start getting the hospitals, we'll try to start opening code rolls, keeping them clean, but showing y'all all this stuff. And that's nice. You don't have to go to the stock room and look for all this stuff. It's in the code card. Okay, so I'm still bagging. Benny has hooked up and turned on the yanker.
So if it's an emergency situation, I'll come in here and hook up the ambu bag, and the intubator is ready, and she's bagging the patient. Right now, it's my job to get everything ready for intubation. So what do I need to do? I need to get my blade ready. Which one you would like, Miller or McIntosh, man?
I like Miller 3.
Miller 3? Okay, it's Miller 2. Okay, I got it. Yeah, I don't have Miller.
All right, Miller 2 then.
So I got this Miller blade. I need to check it. Okay, all is fine. Everything is cool. I got that in the corner. Move this guy there. What size of tube would you like there?
I would like a 6.0.
6.0.
Let's say right now too, I'm having a hard time bagging. I am not getting a good air, I'm not seeing a good chest rise. What else could be going on right now? Not secretions of blood or anything. Of what? The tongue might be falling in the air, back of the airway. I
So
can't
you might
push.
need the Berman or
The oral airway.
oral airway.
We would say that to you. What would you do? I would immediately do this, put it in, turn it into the back, and then bag right over it. You see that all the time in codes.
All right, so you need a 6.0? Do you want a high-low ET tube or regular tube?
Regular.
All right, now, so